Good morning from downtown Everett. On this chilly February day, I'm Colleen Bruce.
And Aracelly Casada.
And I'm Mark Stroud.
And we're reporting today on solution-focused brief therapy. For an overview, Steve Shazer and Insoo Kim Berg, alongside their team, established the steps to solution-focused brief therapy, or SFBT, in Milwaukee, Wisconsin in the early 1980s as a part of systems therapies. The steps were built on the work of others over the previous 50 years. According to the authors of the manual, is a competency-based model concentrated on how clients change rather than on diagnosis and treatment of past problems and failings. From the perspective that change is constant, client strengths and previous successes are used, with emphasis on working with the client's understanding of his or her situation and what he or she would like to be different, in developing desired client-defined and client-led vision of the future where the problem is solved. Exploration of client exceptions, strengths, and resources help to guide him or her toward formulating that self-constructed reality. As far as research literature, Dr. Langer of the SFBT Clinic in Olympia tells us, multiple studies concluded SFBT is equally effective for all social classes. Results are seen in 3 to 5 sessions. 18 of 24 comparison studies show convincing benefit with 1 equivocal. 8 randomized controlled studies show benefit from SFBT, 5 show benefits over existing treatments. There is an overall success rate of 60% with an average of 3 to 5 sessions. SFBT is more effective with internalizing behavior problems such as depression, anxiety, self-concept, and self-esteem, but not as effective with externalizing behavior such as hyperactivity and conduct problems. For therapies, SFBT is based on multiple theories of personality. 1 is constructivism. Client's subjective perception of his or her reality is honored. For 2, post-structuralism. Reality arises from a consensual linguistic process. The worldview, social context, and personal reality are filtered through language. Interactional constructivism. Therapists try to reframe or change the conceptual or emotional point of view. Number 4, constructive alternativism. As problems are reframed, new solution-oriented alternatives are formed. Phenomenological humanistic existential basis, a mouthful of a way to say that FBF and SFBT, they don't believe that the therapist is the expert. And for number 6, finally, also, SFBT does not believe a person's perception is incorrect, maladjusted, or in need of change. SFBT is like a resiliency-based model such as motivational interviewing, and components are similar to cognitive behavior therapy, but rather than the therapist assigning changes and tasks, clients are encouraged to do more of their own exception behavior based on the client's description of his or her own goals. SFBT is also similar to narrative therapy, since it is derived from a non-pathology perspective and client-focused. Plus, there is a component to create new realities. SFBT is least similar to problem or past focus or working through types of therapies. As far as core knowledge, Dr. Langer tells us that SFBT is based on the principles: if it is not broken, don't fix it. If it works, do it more. If it's not working, do something different, and don't try harder if it's not working. Stop doing it. Do something else or view something differently. The manual authors also tell us that SFBT is solution building rather than problem solving. Therapeutic focus is on the client's preferred future instead of current problem and conflict history. Present useful behavior is encouraged. Therapists and clients discover exceptions when problems could have happened but did not, and use those times when the problem did not occur to build solutions. Clients are helped to locate options to unwanted behavioral and thinking patterns using what works currently and building on those successes. The model assumes solution behaviors are inherent in the client rather than other skill building and behavior building type interventions. Small increased changes lead to large increased change. Solutions are not directly related to any identified problem. And therapist skills to inspire the client to build solutions are not the same as those for diagnosing and treating client problems. To be a SFBT therapist, formal training is required, ideally with a master's degree in a counseling discipline. Successful SFBT therapists are warm and friendly, open-minded and flexible, naturally positive and supportive, excellent listeners, tenacious and patient. From a cultural perspective, clinicians should respect differences, not act as if culture is invisible, seek diversity training, and to focus on similarities between people rather than on differences. And now over to Shelley.
Thank you. Solution-focused brief therapy techniques or principles. As a therapist, we will be looking at previous solutions for the problems. We will direct the client with questions instead of interpretation or direct interpretations. Present and future focused questions versus past oriented focus. Numerical question, goal setting, solution focused goals, scaling questions, coping questions, compliments, what is better question. Specific interventions for solution focused brief therapy are one of the major ingredients for this therapy are developing a cooperative therapeutic alliance with the client, creating a solution versus problem focus, setting measurable, changeable goals, focus on the future through future-oriented questions and discussions, scaling the ongoing attainment of the goals to get the client's evaluations on the progress that they're making. Also, focusing on the conversation with the client regarding exceptions to the client's problems, especially those exceptions related to what they want different, and encouraging the client to do more of what they did to make the exception happen. Settings that are used, solution focus brief therapy is used in different settings. One is individual group and groups, including child protective agencies, community mental health clinics, private practices, sexual abuse programs, family-based services, substance abuse counseling, social work, psychology, general counseling, and educational settings. Now to Mark, and he will describe some of the techniques we will be using later.
Thank you, Aracelly. Solution-focused goals, like many models of psychotherapy, are clear, concrete, and specific goals. They're an important component in the SFBT therapy. Whenever possible, the therapist tries to elicit smaller goals rather than larger ones. More important, clients are encouraged to frame their goals as the presence of a solution rather than the absence of a problem. For example, it is better to have as a goal, we want our son to talk nicer to us, which would need to be described in greater detail, rather than it would be nice for our child not to curse at us. Also, if a goal is described in terms of its solution, it can be more easily scaled. Take the miracle question. Some clients have difficulty articulating any goal at all, much less a solution-focused goal. The miracle question is a way to ask for a client's goal in a way that communicates respect for the immensity of the problem. At the same time, it leads to the clients coming up with smaller, more manageable goals. It is also a way for many clients to do a virtual rehearsal of their preferred future. Back to you, Colleen.
So that concludes our discussion of solution-focused brief therapy. For our next video, we will offer a demonstration of the miracle question as one technique, as well as exploration of solution-focused goals. Mark is going to portray our clinician, and he will be talking to Aracelly, and she is going to be portraying a depressed mother of 5 children. We look forward to sharing our examples of intervention skills with you in our next video.